Okay, let's talk about the patient with impairment of consciousness, memory, or cognition. Here we have a case summary. Mr. DD, aged 78 years, lived at home with his wife and carers visiting twice daily. His general practitioner had referred him to a psychiatrist 6 years earlier, after he started experiencing difficulty remembering things. At first, he would forget things like the social arrangements he had made. Later, he started forgetting activities he had engaged in only the day before. His wife had noticed a gradual changing in his personality, in that he became increasingly withdrawn and sullen and at times verbally aggressive. His language deteriorates to the point where he would rumble incoherently, even when there was no one else in the room. Despite having smoked for many years, Mr. DD seemed unable to recognize his pipe and would stare at it quizzically for hours. He lost the ability to dress himself or complete simple multi-step tasks, such as making a cup of coffee. His wife contacted the GP when Mr. DD was too sleepy to get out of bed one morning. The GP arranged hospital admission for further investigation. Nurses were concerned because his consciousness level was fluctuating from hour to hour. He slept through most of the day, but would wander around the ward at night looking very agitated and appeared to have visual hallucinations. The senior nurse pointed out that he had developed a productive cough. So, cognitive impairment is common and important, but often underdiagnosed and underinvestigated. It is associated with a high morbidity and mortality, and you are likely to frequently encounter people with cognitive impairment in most specialties of medical practice. Let's talk about some definitions and the clinical features. Consciousness. To be conscious is to be aware, both of the environment and of oneself as a subjective being. It is a global cognitive function. It is a poorly understood complex phenomenon with multiple vaguely defined terms for its abnormalities. It is best to avoid terms such as confused, obtunded, clouding of consciousness, and stupor, as they are not well defined and mean different things to different specialties. Clinically, the key question is whether someone has a normal or altered conscious level. So these are the major descriptions here. Normal or altered conscious level. This is assessed as at a practical level by observing arousal level, hyper-aroused or lowered. Let's see the figure here. So we have, is the patient awake? If yes, are they agitated, hypervigilant, unable to sleep? If no, this is normal. If yes, this is hyper-aroused. The patient is hyper-aroused. Is the patient awake? No. Are they easily rousable? If yes, do they remain alert throughout assessment? If yes, this is normal. But if no, this is lowered. And of course, if they are not easily rousable, so this is lowered, so consider ABG and Glasgow Coma Scale. So this is the assessment of consciousness level. Okay. About cognition. This chapter considers cognition in its broadest sense as meaning all the mental activities that allow us to perceive, integrate, and conceptualize the world around us. To perceive, to integrate, and conceptualize the world around us. So, Okay. These include the global functions of consciousness, attention, and orientation, and the specific domains of memory, executive function, language, praxis, and perception. So here we have consciousness, attention, orientation, and we have specific domains like memory, executive function, language, praxis, and perception. Okay. The term cognition is also used more narrowly in cognitive psychology and cognitive therapy, where individual thoughts or ideas are also referred to as cognitions. Impairment in cognition can be generalized in multiple domains or specific one domain only. An altered level of consciousness is generally associated with a generalized impairment in all aspects of cognition. It is difficult to concentrate on any tasks when feeling very agitated or drowsy. A large number of specific cognitive impairments exist. Here we have, next we will have a table to look at some of these. These can be isolated impairments, for example, if they are developmental or secondary to a small stroke or occurs together with in order of generalized cognitive impairments such as dementia. Here we have this table that is talking about specific cognitive impairments. Here we have the cognitive domain, the term, and the description. For example, in the cognitive domain of language, we have something like dysphagia or aphasia. The description of that is dysphagia is loss of language abilities despite intact sensory and motor functioning, like difficulty in understanding commands or other words like receptive aphasia, or difficulty using words with correct meaning. This is expressive dysphagia. Not being able to name items correctly despite knowing what they are. This is nominal dysphagia. These are some subtypes of expressive aphasia. Okay. So we have receptive dysphagia, we have expressive dysphagia, and one of these is nominal dysphagia. What about praxis? The cognitive domain of praxis, we have the term dyspraxia or apraxia. What is that? It is the loss of ability to carry out skilled motor movements despite intact motor function. For example, inability to put a letter in an envelope, use a tin opener, button up a skirt. So these some skilled motor movements. What about perception? Problems with perception like dysagnosia or agnosia, these are, this is loss of ability to interpret sensory information despite intact sensory organ function, like not able to recognize faces as familiar. What about memory? The term of impairment here is amnesia. What's amnesia? The loss of ability to learn or recall new information. For example, not able to recall time or recent events, not able to learn new skills. We have types of memory, as you know. Executive function, this is the umbrella term for many abilities. We have multiple terms to describe the impairment, like disinhibition, perseveration, apathy, dysexecutive syndrome. So what's that? Loss of ability to plan and sequence complex activities, or to manipulate abstract information, like not be able to plan the preparation of a meal, not able to return to a task once distracted. So these are some examples here. So what about memory? Memory is one of the commonest cognitive domains to be impaired. There are two main ways to categorize memory: the duration of storage. So We divide that according to the duration of storage, like working or long term, or the type of information stored, implicit or explicit. Explicit memory, sometimes called declarative memory, includes all stored material of which the individual is consciously aware and can thus declare to others. This is explicit memory or declarative memory. While implicit memory, sometimes called procedural memory, includes all material that is stored without the individual's conscious awareness, like the ability to speak a language or ride a bicycle. So, explicit memory is the most common type of memory to be disrupted. It can be further subdivided into semantic and episodic memory. Semantic and episodic. Semantic memory is knowledge of facts, like Edinburgh is the capital of Scotland. This is a fact, this is semantic memory. Episodic memory, on the other hand, is knowledge of autobiographical events, like remembering a trip to Edinburgh when you were 10 years old. Now we will see a table for the characteristics of different durations of explicit memory and how to test them. So, about explicit memory types, disorders and tasks. First, we have working short memory. The capacity and duration, the capacity of it is 7 plus minus 2 items, and the duration of that is 15 to 30 seconds. Where the key region in the brain, it is within the frontal cortex. The test for that is recall of unrelated words like lemon key ball, to ask the patient to recall these at the moment. So this is short or working memory. What about long-term but recent? We have long-term recent and remote memory. Okay. Recent memory or long-term recent memory, the capacity duration is unlimited and the duration is minutes to months. The key brain regions are hippocampus and mammillary bodies. How we test that? For anterograde memory, we ask delay recall of an address or objects. Retrograde, we may have some questions about recent events, like what did you have for breakfast? Okay. About remote long-term memory, the capacity is unlimited and the duration is lifetime, and the key brain regions here are frontal and temporal cortex. How we test that? Questions about past important events, ask about personal events, like even episodic, like what school did you attend, and general knowledge, like which US president was assigned in 1960s, according to the case, of course. So here we have a communication tip. There are different ways of classifying memory, and different terms have similar or overlapping meanings. For example, some clinicians use the term short-term memory to mean recent long-term memory, whereas others mean working memory. When speaking to colleagues, it can be useful to define the type of memory referred to by the name of the test used to measure it. This is good. Okay. Amnesia refers to the loss of ability to store new memories or retrieve memories that have previously been stored. This is amnesia. Anterograde amnesia is when the patient is unable to store new memories, impaired learning of new materials. This is anterograde amnesia. Although the ability to retrieve memories stored before before the event or onset of disorder may remain unimpaired. Anterograde amnesia usually results from damage to the medial temporal lobes, especially the hippocampal formation. Okay, this is anterograde amnesia. Retrograde amnesia results in patients unable to retrieve memories, although the ability to store new memories may remain unaffected. Retrograde amnesia usually results from damage to the frontal or temporal cortex. Hints and tips. Implicit memory or procedural memory is typically preserved despite severe disruptions to explicit declarative memory, probably due to its independent neural location. Implicit memory is associated with basal ganglia circuitry. Explicit memory is associated with the hippocampal, the encephalic, and cortical structures. Okay? So, common cognitive disorders. Let's talk about these. Delirium. Delirium can be thought of as acute brain failure. It is a syndrome manifesting as acute or fluctuating cognitive impairment associated with altered consciousness and impaired attention. If someone is newly disoriented and is drowsy or agitated, they are very likely to have delirium. Psychotic features such as hallucinations or persecutory delusions are often present, but are not essential to make the diagnosis. Delirium often fluctuates, so a patient may appear normal on the morning ward in the morning ward round, but cognitively impaired and agitated in the evening. Delirium is a final common pathway of severe injury to the brain or body and is a marker of severity of illnesses, like the C in the curves score for severity of community-acquired pneumonia. It is usually multifactorial and often arises from illnesses that do not directly affect the brain. Let's see the box here. The box here is talking about causes of delirium. It is anything that disrupts homeostasis. We have environmental changes or stress, drugs use or discontinuation, systematic illnesses, and we have intracranial causes. For environmental changes or stress, we have hospital admission is one of the factors, particularly intensive care in the ICU, urinary catheterization, use of physical restraint, major surgery, sleep deprivation. These are some environmental changes. What about the drugs? Either use or discontinuation. We have some prescribed drugs plus many more like antipsychotics, benzodiazepines, opiates, antiparkinsonian drugs, steroids. About some recreational materials like alcohol, delirium tremens is one of the causes of delirium, of course. Opiates, cannabis, amphetamines. Poisons like heavy metals like lead, mercury, and manganese, and carbon monoxide, of course. Systematic illnesses like infections and sepsis, of course, can cause that. Hypoxia, because of respiratory failure, heart failure, or myocardial infarction. Metabolic and endocrine causes like dehydration, electrolyte disturbances, renal impairment, hepatic encephalopathy, porphyria, hypoglycemia, hyper and hypothyroidism, hyper and hypoparathyroidism, hyper and hypoadrenocorticorism. We are talking about Cushing's and Addison's. Hypopituitarism, of course. Natural and nutritional causes like thiamine deficiency, it can be, we call it Wernicke's encephalopathy. We see that in alcoholics. Vitamin B12, folic acid, and niacin deficiency. Trauma, any fracture, but frequently hip fracture can cause that. Intracranial causes like space-occupying lesions like tumors, cysts, abscesses, hematomas, all of these space-occupying lesions. Head injury, especially concussion. Infections for the, intracranial infections like meningitis and encephalitis. Epilepsy, of course. Cerebrovascular disorders like TIA, transient ischemic attack, cerebral thrombosis or embolism, intracerebral or subarachnoid hemorrhage, hypertensive encephalopathy, and of course vasculitis from SLE or so on. So let's continue with the text about delirium. It has a high mortality, which around a third of people with delirium dying during the presentation. It is therefore a medical emergency, and the cause should be thoroughly investigated and treated. It is particularly common in those with at-risk brains, such as those with pre-existing dementia, of course. In individuals with vulnerable brains, a relatively minor insult can result in delirium, like dehydration or a new medication. Delirium is also a risk factor for development of or worsening of dementia. Delirium usually resolves when the cause is treated, but sometimes can be prolonged for weeks or months. The terms acute confusional state and encephalopathy have roughly the same meaning as delirium. Prominent symptoms of delirium are described further below. There are three main subtypes: hyperactive, hypoactive, and mixed. Some hints and tips. Key risk factors for delirium are an abnormal brain like dementia, previous serious head injury, or alcohol misuse, age in children and adults over 65 years, polypharmacy, and sensory impairment. All of these are risk factors. The four key diagnostic features of delirium are impaired consciousness, impaired attention, and impaired cognition, all with acute or fluctuating onset. Again, impaired consciousness, impaired attention, impaired cognition, all with acute or fluctuating onset. Supportive diagnostic features are perceptual and thought disturbance, sleep-wake cycle disturbance, and mood disturbance. What about impaired consciousness? Patients may have a reduced level of consciousness ranging from drowsiness to coma, hypoactive delirium, or they can be hypervigilant and agitated in hyperactive delirium. Impaired attention. Ability to sustain attention is reduced, and patients are easily distractible. Assess attention using tests such as serial sevens or months of the year backwards. Impaired cognitive function. Short-term memory and recent memory are impaired with relative preservation of remote memory. Patients with delirium are almost always disoriented to time and often to place. Orientation to self is seldom lost. Language abnormalities such as rumbling, incoherent speech, and an impaired ability to understand are common. Perceptual and thought disturbance. Patients may have perceptual disturbances ranging from misinterpretation, like a door slamming is mistaken for an explosion, or illusions like a crack in the wall is perceived as a snake, to hallucinations, especially visual hallucinations, are to a lesser extent auditory. Transient persecutory delusions and delusions of misidentification may occur. Sleep-wake cycle disturbance. Sleep is characteristically disturbed and can range from daytime drowsiness and nighttime hyperactivity to a complete reversal of the normal cycle. Nightmares experienced by patients with delirium may continue as hallucinations after awakening. Mood disturbance. Emotional disturbances such as depression, euphoria, anxiety, anger, fear, and apathy are common. Here we have two red flags. A physical illness should always be sought when a patient presents with visual hallucinations in isolation, because patients with schizophrenia or psychotic mood disturbances or disorders usually also experience auditory hallucinations. Another red flag. Delirium is a medical emergency. Around a third of people with delirium die during an episode of delirium. Thoroughly assess for and treat the probable cause. Another red flag. Medication is one of the easiest causes of delirium to reverse. Always check the patient's prescription. The top three drug classes which precipitate delirium are benzodiazepines, anticholinergics, and opiates. Dementia. Dementia is a syndrome of acquired progressive generalized cognitive impairment associated with functional decline. Conscious level is nearly always normal. So, we are done with delirium, now we are talking about dementia. So, dementia is a syndrome of acquired progressive generalized cognitive impairment associated with functional decline. Conscious level is nearly always normal. Symptoms should be present for 6 months before a diagnosis can be confirmed. The following text describes the general categories of impairment in dementia. Functional impairment. Functional impairment must be present to make diagnosis of dementia. Functional impairment means difficulties with basic or instrumental activities of daily living. Basic activities of daily living refer to self-care tasks such as eating, dressing, washing, toileting, continence, and mobility. Being able to make crucial movements such as from bed to chair to toilet and so on. Instrumental activity of daily living refers to tasks which are not crucial to life but which allows someone to live independently, such as cooking, shopping, and housework, as well as being diagnostically important. Someone's ability to perform activities of daily living determines what level of support they need, home carers or 24-hour residential care. Memory impairment. Impairment of memory is a common feature of dementia. Recent memory is first affected, forgetting where objects are placed, conversations and events of previous day. With disease progression, all aspects of memory are affected, although highly personal information like name, previous occupation, etc. is usually retained until late in the disease. Note that memory is essential for orientation to person, place, and time, and this will also be gradually affected. For example, patients may lose their way in their own house. Other cognitive symptoms: aphasia, apraxia, agnosia, impaired executive functioning. We've talked about these. Let's talk about behavioral and psychological symptoms of dementia. Behavioral and psychological symptoms of dementia is an umbrella term for non-cognitive symptoms associated with dementia, BPSD, including changes in behavior, mood, and psychosis. Behavioral symptoms are very common and include pacing, shouting, sexual disinhibition, aggression, and apathy. Depression and anxiety may occur in up to 50% of all those with dementia. Delusions, especially psychiatry, may occur in up to 40%. Hallucinations in all sensory modalities, visual is more common, occur in up to 30% of patients. BPSD can be similar to symptoms of delirium, but generally has a more gradual onset, and conscious level is usually normal. Next, we have a table that for more ways to differentiate BPSD from delirium. So here we have some factors that differentiating delirium from dementia. The onset usually for delirium is acute and for dementia is gradual, the onset of that. The duration of delirium is from hours to weeks, while for dementia it's months to years. The attention is impaired in delirium and not in dementia. The course is fluctuating in delirium and progressive, and it has progressive deterioration course in dementia. Consciousness is altered in delirium and it is normal usually in dementia. The context, it may be because of new illness and medication in delirium, while in dementia it is with health, without any kind of health changing, usually. Perceptual disturbances are common in delirium, occurs in late stages in dementia. Sleep-wake cycle is disrupted in delirium and usually normal in dementia, especially at first. Orientation usually impaired for time and unfamiliar people and places in delirium, but it is impaired in late stages in dementia. Speech is incoherent and rapid or slow in delirium, and in dementia it can be something like word finding difficulties. Things you may think, why in delirium you think, why aren't they listening? Why won't they wake up properly? Why need to calm down? While in dementia, why do they keep telling me about the past? Why do they keep asking me the same question? So these are the things that the patient may think about and complain about. Okay. Neurological symptoms. Between 10% and 20% of patients will experience seizures. Primitive reflexes like grasp, snout, and suck, and myoclonic jerks may also be evident. Communication tip here. When seeing a new patient with a likely diagnosis of dementia, always take a collateral history, as patients may have poor insight and recall of their difficulties. Distinguishing the type of dementia. Dementia can result from a primary neurocognitive processes or be secondary to substance use or another medical condition. Early onset dementia begins before age 65 years. A small number of cases are due to treatable, potentially reversible causes. Here we have the box that is talking about the diseases that may cause dementia. So here we have some diseases that may cause dementia. We have neurodegenerative causes, cerebrovascular disease, space-occupying lesions, trauma, infections, metabolic and endocrine, nutritional, drugs and toxins, chronic hypoxia, inflammatory disorders, and normal pressure hydrocephalus. Neurocognitive causes of dementia like Alzheimer's disease, frontotemporal dementia including Pick's disease, dementia with Lewy bodies, Parkinson's disease, Huntington disease, progressive supranuclear palsy. Cerebrovascular disease like vesicular dementia, mixed Alzheimer and vascular dementia. Vascular dementia and mixed Alzheimer and vascular dementia. Space-occupying lesions like tumors, cysts, abscesses, hematomas. Trauma like head injury, dementia pugilistica, which is sometimes called punch-drunk syndrome. Infections like Creutzfeldt-Jacobs disease, including the new variant of CJD, HIV-related dementia, neurosyphilis, viral encephalitis, chronic bacterial and fungal meningitis, and so on. Okay. Metabolic and endocrine, like chronic renal impairment, also called dialysis dementia, liver function, Wilson disease, hyper and hypothyroidism, hyper and hypoparathyroidism, Cushing syndrome, and Addison disease. Nutritional causes like thiamine, vitamin B12, folic acid or niacin deficiency, pellagra. Drugs and toxins like alcohol, benzodiazepines, barbiturates, and solvents. Chronic hypoxia. Inflammatory disorders like multiple sclerosis and systemic lupus erythematosus. Normal pressure hydrocephalus is one of the causes, of course. However, the most common causes of dementia are neurodegenerative and the vascular disease. Here we have a table that describes the distinguishing clinical features of the various types of dementias, although clinically it is often difficult to tell what form of dementia is present, and definitive diagnosis can normally only be made by post-mortem examination. So let's go to the table that has some distinguishing clinical features of the commonest types of dementia. Alzheimer's dementia, which represents 62% of patients with dementia, have these distinguishing clinical features like gradual onset and with progressive cognitive decline. Okay, so gradual onset with progressive cognitive decline and with early memory loss, while vascular dementia, multiple infarct dementia, which accounts for 17%, would have some focal neurological signs and symptoms, evidence of cerebrovascular disease or stroke, and may be uneven to stepwise deterioration in cognitive functioning. Okay, so we have this stepwise deterioration. This is important here. Okay, what about mixed dementia, which accounts for about 10%? Features of both Alzheimer's and vascular dementia, of course. Lewy body dementia, which accounts for 4%, the core features are day-to-day or shorter fluctuations in cognition performance, recurrent visual hallucinations, this is important, motor signs of Parkinsonism, this is also important, rigidity, bradykinesia, tremors, and of course it should be not drug-induced. And we have some clinical features that support these the Lewy body dementia, like REM sleep behavior disorder, recurrent falls and syncope, transient disturbances of consciousness, extreme sensitivity to antipsychotics, including includes Parkinsonism. While others like frontotemporal dementia, including Pick's disease, which accounts for 2% of dementia cases, we have some behavioral variants like early decline in social and personal conduct, disinhibition and tactlessness, dietary changes, preferences for sweet food, early emotional blunting and loss of insight, primary progressive aphasia, non-fluent and semantic variants, attenuated speech output, echolalia, perseveration, mutism, and so on, loss of semantic knowledge and naming, relative sparing of other cognitive functions. Okay, what about Parkinson's disease with dementia, which accounts for about 2%? Diagnosis of Parkinson's disease, you need that. Motor symptoms over a year prior to cognitive symptoms. Dementia features very similar to those of Lewy body dementia, but the timing of motor symptoms and cognitive symptoms would tell you the right diagnosis, of course. Okay. It is important to establish the likely underlying type of dementia. Why is that? Because a secondary dementia causing process like brain tumor may be detected and possibly treated. And because the progress of certain types of dementia may be slowed with specific medications like cholinesterase inhibitors in Alzheimer's disease. Certain drugs may be contraindicated in some dementias, like antipsychotics, can cause a catastrophic Parkinsonian reaction in patients with dementia with Lewy bodies. And because the prognosis of the various dementias differ, this may have practical implications for patients and their families as regards final arrangements like wills. The patient's relatives may inquire about genetic counseling, of course, like Huntington disease, early onset Alzheimer's dementia. In a minority of causes, the distinction will be obvious based on other symptoms produced by the disease process, like jerky movements of the face and body, chorea, and a positive family history. All of these would be suggestive of Huntington's disease. In the majority of cases, the different dementias may be distinguished to some degree based on a detailed history from the patient and an informant, physical examination, relevant investigations, and follow-up over time. However, the definitive diagnosis of dementia subtype can only be established with absolute certainty on detailed microscopic examination of the brain at autopsy, and even then, a conclusive diagnosis may not be possible. To aid the clinical distinction of dementia, some authors differentiate cortical and subcortical and mixed dementia. So they differentiate cortical, subcortical, and mixed dementias based on the predominance of cortical or subcortical dysfunction, or mixed of the two. Here we have a table for the features of cortical and subcortical dementias. We have these characteristics for cortical and subcortical dementias. But to know what we are talking about, cortical dementias like Alzheimer's disease and the frontotemporal dementias including Pick's disease, while subcortical like Parkinson's disease, dementia with Lewy body, Huntington disease, progressive supranuclear palsy, Wilson's disease, normal pressure hydrocephalus, multiple sclerosis, and HIV-related dementia. Mixed dementia like vascular, of course, infection-induced dementia like Creutzfeldt-Jakob disease, neurosyphilis, and chronic meningitis. Let's talk about some of these characteristics. For cortical dementia, the language for that would have some aphasia. The aphasia would be early. Subcortical dementia, the language would be normal. For speech, in cortical dementia, normal until late, while in subcortical dementia, there may be dysarthric patients. Okay. So language is normal, but dysarthria, because it has something to do with motor functioning and so on. While in cortical dementia, there would be aphasia, but the speech would be normal. Praxis. In cortical dementia, there would be some apraxia. Cortical dementia. In subcortical dementia, no, it's normal. Agnosia. Present in cortical dementia, usually absent in subcortical dementia. Calculations. There would be early impairment in cortical dementia, but in subcortical dementia would be normal until late. While for motor system, in cortical dementia, things would be normal. Usually normal tone, normal posture. While for subcortical dementia, there would be stooped or extended posture, increased tone, and so on. Extra movements in cortical dementia, usually there is no such thing. May have myoclonus in Alzheimer's disease, but usually there is nothing like that. While in subcortical dementia, there would be tremors, chorea, and tics, and so on. So, and you can see from the examples, we are talking about Parkinson's disease, of course, there would be motor things. Dementia with Lewy body is the same thing, Huntington's the same thing, and so on. Yeah. Okay. Unfortunately, there is often a considerable overlap of symptoms in advanced dementia with whatever type. Hints and tips. At this point, you might find it helpful to read up on the etiology and neuropathology of the various neurocognitive domains. We will talk about these in chapter 19. When we talk about the causes, Differential diagnosis. There are 4 key questions when a patient presents with possible cognitive impairment. Is there objective evidence of cognitive impairment on a standardized test? If so, is it acute, chronic, or acute on chronic? This may require a collateral history. Is the patient's conscious level normal or abnormal? What impact is the cognitive impairment having on the patient's functioning? So, we are done here about dementia. We are talking about differential diagnosis in general for patients with cognitive impairment. So we ask ourselves these questions. Is there any objective evidence? Is this acute, chronic, or acute on chronic? What about the consciousness level? So, and the impact, of course. Here we have a figure for diagnostic algorithm and a box for summary of differential diagnosis. So, we have cognitive symptoms. Is there is normal score on standardized testing? If normal score, so we may have subjective cognitive impairment. But if the score is not normal, we ask ourselves if these symptoms are acute or fluctuating. If acute, yes, we are talking about delirium most likely. If no, we look for depressive symptoms. If depression is there, so it may be something like depression. So we reassess cognition once the depression is treated, because depression can have some cognitive impairment. If no depressive symptoms, we look for activities of daily living, if these are affected or not. If these activities of daily living are not affected, we are talking about mild cognitive impairment. If daily living activities are affected, we are asking about ourselves about this. Are these symptoms progressive, worsening over at least 6 months? If yes, we are talking about dementia. If no, this may be stable impairment. And if this is stable impairment, we are talking about stable cognitive impairment. Dementia is progressive, as you know. Again, cognitive symptoms. If normal, so this is subjective cognitive impairment. If not, we are looking for it is acute or fluctuating or not. If acute or fluctuating, we are talking about delirium. If not, we look for depressive symptoms. If yes, treat depression and reassess. If no depressive symptoms or still there's something wrong after treatment, we ask ourselves this question about activities of daily living. If not affected, we are talking about mild cognitive impairment. If yes, affected, so it's and more than 6 months and progressive, we are talking about dementia. If not progressive, we are talking about stable in cognitive impairment. So that's it, generally. Acute on chronic or fluctuating cognitive impairment, delirium. See common cognitive disorders section earlier for clinical features of delirium. We've talked about that. So here we will talk about, the differential diagnosis. But let's just, go to the box here. Differential diagnosis of cognitive impairment. So these are delirium. We've talked about that. Dementia. We have mild cognitive impairment. We have subjective cognitive impairment. We have stable cognitive impairment post-insult, like stroke, hypoxic brain injury, traumatic brain injury. After this injury would be some cognitive impairment, but it would be stable. That's obvious. Depression, we call dementia then pseudo-dementia. We have psychotic disorders, mood disorders, intellectual disability, dissociative disorders, factitious disorder or malingering, amnesic syndrome. So let's talk about them. We've talked about acute on top of chronic or fluctuating symptoms. We are talking about delirium. We've talked about that. Chronic cognitive impairment. Key questions when patient present with chronic cognitive impairment. So which cognitive domains are impaired? One domain or many? Is the impairment stable, fluctuating, or progressive? Is the cognitive impairment causing functional impairment or not? Are there any other associated symptoms? Mood change, personality change, perceptual disturbance? Chronic impairment in multiple cognitive domains is due to most often to dementia, mild neurocognitive or mild cognitive impairment, or depression. So when we are talking about chronic impairment of multiple cognitive domains, this would be mostly due to dementia, mild cognitive impairment, or depression. Sometimes patients with an isolated impairment, most often due to head injury or stroke. Causes of isolated amnesic syndrome, are considered in more detail at the end of this section. But you should know that. So we are talking about more than one domain. We are talking about dementia, mild cognitive impairment, or depression. Okay, red flag. Lewy body dementia and multiple infarct dementia are the only dementias that feature transient episodes of impaired consciousness as a typical feature. All other dementias do not feature an impairment of consciousness unless complicated by delirium. Dementia, we've talked about that, and we will talk about them later on in cognitive disorders, Older adults presenting with both physical health problems and generalized cognitive impairment are very common. And it is imperative that you understand how to differentiate between dementia and delirium. We've talked about that, the things that can differentiate delirium from dementia. Okay. What about mild cognitive impairment? Mild cognitive impairment is objective cognitive impairment confirmed with a standardized test that does not interfere notably. So this is objective, not subjective, but it is not interfering notably with activity of daily living. Mild cognitive impairment is a risk state of dementia, with around 10% to 15% of patients developing dementia each year. However, in some cases, the impairment remains stable or even improves. All the processes that cause dementia can also cause mild cognitive impairment, so it is normally investigated in the same way. What about subjective cognitive impairment? Subjective cognitive impairment is when a patient complains of cognitive problems but scores normally or on standardized tests. It can reflect anxiety or depression, but can also represent early deterioration in a highly educated individual that is unidentifiable using standard tests. People with subjective memory impairment are at increased risk for later developing mild cognitive impairment or even dementia. What about stable cognitive impairment? Some one-off insult to the brain can impair one or more aspects of cognition but not cause progressive deterioration. For example, following a stroke, hypoxic brain injury, traumatic brain injury, or viral encephalitis. Improvement post-insult can occur over several months. So it's important not to make a firm diagnosis of stable chronic impairment too soon. Often, someone who has had one cerebrovascular event continues to have further episodes. So an initial stable post-stroke cognitive impairment can evolve into vascular dementia, of course. Depression. Depressive pseudodementia is a term sometimes used when patients present with clinical features resembling a dementia that result from an underlying depression. Both depression and dementia can be associated with a gradual onset of low mood, anorexia, sleep disturbance, and generalized cognitive and functional impairment. And they can be very difficult to distinguish. If there is uncertainty, treatment for depression is trailed, and cognition rechecked after mood has improved. Unfortunately, depression presenting with cognitive impairment is a risk factor for later developing dementia. Psychosis. Patients with schizophrenia often have multiple cognitive deficits, particularly relating to memory. But unlike dementia, the age of onset is earlier, and psychotic symptoms are present from the start. An acute psychotic state may resemble a delirium due to disturbed behavior, vivid hallucinations, distractibility, and thought disorder. However, patients generally remain oriented and symptoms do not fluctuate to the same degree as in delirium. Intellectual disability. Patients with intellectual disability have an IQ below 70 with an impaired ability to adapt to their social environment. Unlike dementia, intellectual disability manifests in the developmental period before age 18 years, and the level of cognitive functioning tends to be stable over time, not progressively deteriorating. However, intellectual disability can be comorbid with dementia or delirium. Around 50% of people with Down syndrome will develop Alzheimer's dementia, often early onset. Dissociative disorders. Memory loss and altered conscious levels can occur in the dissociative disorders like dissociative amnesia, fugue, and dissociative disorders like and Sqour. These usually occur in young adults. However, there is no evidence of a physical cause, and they are usually precipitated by psychosocial stressors. Factitious disorder and malingering, we'll talk about this later on. Amnesic syndrome. While amnesia is the most common cause of chronic memory dysfunction overall, certain brain causes can cause a severe disruption of memory with minimal or no deterioration in other cognitive functions. This is termed amnesic syndrome and usually results from damage to the hypothalamic diencephalic system or the hippocampal region. The amnesic syndrome is characterized by all of the following. First, anterograde and retrograde amnesia. The impairment of memory for past events is in reverse order of their occurrence. Recent memories are the most affected. Okay. There is no impairment of attention and or consciousness or global intellectual functioning. There is also no defect in working memory as tested by digit span. Here we have a book that is talking about causes of amnesic syndrome. We have diencephalic damage and hippocampal damage. Diencephalic damage, like in vitamin B1 thiamine deficiency, Korsakoff syndrome, chronic alcohol abuse, would be caused by chronic alcohol abuse, gastric carcinoma, severe malnutrition, hyperemesis gravidarum, bilateral thalamic infarction, multiple sclerosis, post-subarachnoid hemorrhage, third ventricular tumors, and or cysts. Hippocampal damage, like in bilateral posterior cerebral artery occlusion, carbon monoxide poisoning, closed head injury, herpes simplex virus encephalitis, and transient global amnesia. These are some causes of, and are the causes of amnesic syndrome. Okay, another part of, we are talking about, the characteristics of amnesic syndrome: anterograde and retrograde amnesia, no impairment of attention or consciousness or global intellectual functioning. And there is strong evidence of brain disease known to cause the amnesic syndrome. Although there is no impairment of global cognitive functioning, patients with the amnesic syndrome are usually disoriented in time due to their inability to learn new material, anterograde amnesia. Other associated features are confabulation, filling of gaps in memory with details which are factitious but often pleasurable, lacks of insight and apathy. The commonest cause of amnesic syndrome is thiamine deficiency, resulting in Wernicke's encephalopathy, followed by Korsakoff syndrome. We'll talk about this in chapter 8 in details. Here we have some hints and tips. Due to their unimpaired intellectual functioning, maintained communication and language skills, tendency to confabulate, and lack of insight, patients with an amnesic syndrome can present as problem-free, therefore as in dementia. A collateral history is crucial. Assessment. Okay, for assessment for patients with cognitive impairment, start with history. The following questions may be helpful in eliciting symptoms of cognitive impairment to the patient. We have something to the patient and things for the informant. To the patient, do you find yourself forgetting familiar people's names? Do you get lost more easily than you used to? Are you able to handle money confidently? Do you feel being forgetful is stopping you from doing anything? To the informant, we ask, are they repetitive in conversation? Has their personality changed? Are they having difficulty with aspects of their day-to-day life? Do you have any concerns about their safety? On examination, we have cognitive examination. The key when assessing cognition is to use a standardized test and avoid vague descriptions such as alert and oriented. Many patients maintain a good social veneer, making it surprisingly easy to miss cognitive impairment if it is not formally assessed. There is a wide range of tests available of varying comprehensiveness, length, and generalizability across cultures. The one you choose depends on the time available and degree of concern about the patient's cognition. In the UK, it is recommended that all hospital inpatients aged more than 65 years have their cognition screened, whether or not they appear impaired. Here we have a table that lists the advantages and disadvantages of some widely used screening tests. We have the AMT, which is the abbreviated mental test, and we have the Montreal Cognitive Test, and we have the Addenbroke's Cognitive Examination 3. For the AMT, the time performed is within 3 minutes. The advantage of that, it is fast. The advantage, it's not sensitive to mild to moderate impairment. While the Montreal Cognitive Test, it takes about 10 minutes. The advantages here are the tests. It tests all cognitive domains and it is sensitive to mild to mild impairment. The disadvantages here influenced by premorbid IQ, language, and culture. Tester needs to practice prior to administration. While the ACE3, it takes about 20 minutes. It tests all cognitive domains and it's sensitive to mild impairment. But the disadvantage here, the length of it, and the influence by the premorbid IQ, language, and culture, of course. Okay. There are many more cognitive tests which can be useful for specific disorders. The Wisconsin CAR test to assess frontal lobe function, for example. So here we have some assessment of conscious level. This described it. Assessment of conscious level is described in figure 1. We've talked about that. Anyways, hints and tips. Try to ensure the result of a cognitive assessment reflects cognitive abilities rather than other difficulties as far as possible. Check for medications which may be influencing cognition. Ensure the patient has their glasses and or hearing aid, is not hungry, needing the toilet, or exhausted. Okay. About physical examination. Physical examination, including a neurological examination, is important in everyone with cognitive impairment, as it may provide evidence of reversible causes of impairment such as hypothyroidism or a space-occupying lesion. Risk factors for dementia like hypertension or atrial fibrillation. Differential diagnosis of dementia like hemiparesis or visual field defects that suggestive of stroke and hence increased risk for vascular dementia. Complications of impairment such as self-neglect or injuries from falls. Factors that may influence future prescribing decisions like bradycardia should lead to caution with cholinesterase inhibitors, for example. What about investigations? The main aim of investigations is in cognitive impairment is to exclude reversible causes. Here we have a table that is talking about that. So typical CT appearances for the main forms of dementia. In normal aging, there would be progressive cortical atrophy and increasing ventricular size. In Alzheimer's, there would be generalized cerebral atrophy, widened sulcide, dilated ventricles, thinning of the width of the medial temporal lobe in temporal lobe oriented CT scans, and so on. In vascular dementia, you may find single or multiple areas of infarction, cerebral atrophy, and the dilated ventricles. In frontotemporal dementia, the greater relative atrophy of frontal and temporal lobes. There would be knife blade atrophy. This is the appearance of atrophied gyri. In Huntington's disease, there would be dilated ventricles, atrophy of caudate nuclei, and the loss of the shouldering. In CJD, CJD usually appears normal. It is usually fast, quickly progressive, so the changes would be not there. While in the new variants of CJD, this had characteristic MRI picture, which is a bilaterally evident high signal in the pulvinar postthalamic region. Anyways. In delirium, additional investigations for, let's get back to the text. Here we are talking about investigations. So in delirium, additional investigations for acute illness are likely to be appropriate, including the ECG and septic screen in the presence of infective symptoms or pyrexia, according to the case. Although some types of dementia have characteristic radiologically, these differences are not yet robust enough to be diagnostic. In some rarer forms of dementia, genetic testing may be useful, like in Huntington's disease and an early onset Alzheimer's. If the diagnosis is in doubt or atypical, a more detailed cognitive assessment by a neuropsychologist may be of benefit, usually assessed by a memory clinic. Here we have some investigations also recommended for chronic cognitive impairment, for example, vitamin B12 and folate level to detect nutritional deficiency and malabsorption, thyroid function test, calcium, glucose, urea, and electrolytes to detect hypothyroidism, hypercalcemia, Cushing's, and adenosines. CT and MRI can detect, subdural hematoma, tumor, normal pressure, hydrocephalus. Okay. Let's discuss this study that we've talked about at the beginning of this chapter. Let's get back to it. Okay. Mr. Didi, aged 78 years, lived at home with his wife, with carers visiting twice daily. His general practitioner had referred him to a psychiatrist 6 years earlier, after he started experiencing difficulty remembering things. At first, he would forget things like the social arrangements he had made. Later, he started forgetting activities he had engaged in only the day before. His wife had noticed a gradual change in his personality, in that he became increasingly withdrawn and sullen, and at times verbally aggressive. His language deteriorated to the point where he would ramble incoherently, even when there is no one else in the room. Despite having smoked for many years, Mr. Didi seemed unable to recognize his pipe and would stare at it quizzically for hours. He lost the ability to dress himself or complete simple multiple tasks, such as making a cup of coffee. His wife contacted their GP when Mr. Didi was too sleepy to get out of bed one morning. The GP arranged hospital admission for further investigation. Nurses were concerned because his consciousness level was fluctuating from hour to hour. He slept through most of the day, but would wander around the ward at night, looking very agitated and appeared to have visual hallucinations. The senior nurse pointed out that he had developed a productive cough. I think the patient is, dementic. He has dementia, and in addition to that, he developed delirium acutely, so acute on top of chronic. Let's discuss that. Mr. DD first presented with memory loss for recent events. His personality gradually changed, withdrawn, prone to verbal aggression, and he also developed numerous other cognitive deficits like aphasia, rumbling incoherently, agnosia, unable to recognize his pipe, apraxia, unable to dress himself, and impaired executive functioning, unable to make a cup of coffee. This 6-year deterioration in cognitive and functional abilities associated with a normal level of consciousness suggests the diagnosis of dementia. Mr. DD then developed a delirium, as evidenced by the rapid onset of fluctuating conscious level, disrupted sleep-wake cycle, psychomotor agitation, and apparent perceptual disturbances like visual hallucinations. It is crucial that the cause of the delirium is diagnosed and treated. In this case, it would be pneumonia, as Mr. DD had developed a productive cough. Now you can go to chapter 19 to read about delirium and dementia and their management. Here we have chapter summary. Cognitive impairment is common and associated with high morbidity and mortality, but is often under-recognized. Delirium is a syndrome of impaired consciousness, impaired attention, and impaired cognition, all with acute or fluctuating onset. Dementia is a syndrome of acquired, generally progressive, generalized cognitive impairment associated with functional decline. Always assess cognition using a standardized cognitive test. A collateral history is often crucial to establish the temporal pattern of cognitive difficulties and degree of functional impairment. Always screen for treatable causes of delirium and dementia. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.